So at this point in time, there is no established strategy to prevent relapse after transplant. Lots of investigations are being proposed, but as a standard, especially post-allogeneic transplant, there is none. So I believe clinical research in the field is coming to realize that relapse has become the most important challenge in the field, especially with improvement in early toxicity from the preparative regimens for transplant. So the post-transplant period of time becomes a very fertile area for research. So I believe strategies that are coming after the transplant will be very prevalent in the next decade. There are two ways to approach this, especially for AML and myelodysplastic syndrome. One of them is to look at the specific mutations that the patient had before transplant. They do not necessarily will be present afterwards. However, it stands to reason that strategies aiming at these mutations will be investigated. So one of them is FLT3 inhibitors, which are under current investigation in international studies, and also possibly IDH1 and IDH2 mutations and their drugs that target those mutations. The second general approach is to look at this from a more immunologic standpoint. So there are drugs that have been postulated to manipulate the graft versus leukemia effect. For example, they all tend to be around a group of drugs called hypomethylating agents or histone deacetylase inhibitors. They both have this ability to not be incorporated in the DNA and yet manipulate the immune system favorably. So this is a more general approach that would not be mutation specific.